everyone, and thank you for joining the NeedyMeds special topic webinar, Shine, Information and Counseling for Medicare Beneficiaries of All Ages. My name is Carla, and I am the Education Coordinator here at NeedyMeds. And before we get started with today's presentation, I want to go over a few things. You can certainly feel free to type your questions into the questions section of your GoToWebinar control panel, but all questions will be answered at the end of the webinar. If we don't have the time to answer your particular question, we will follow up with you personally via email by tomorrow at the latest. Just so you know, also this webinar is being recorded, and as soon as we can, what we'll do is we'll convert it into a video and post it on the NeedyMeds YouTube page. So with that, let's get started. For those of you that are not familiar with NeedyMeds, we are a national nonprofit organization, and right up on your screen now is a shot of our current homepage. And I always put that slide up because our website and of course the people that work our call center are really the face of our organization. As I said, we are a national nonprofit, and our mission is to educate and empower those seeking affordable health care. And we define education in two ways. One, certainly by educating people about NeedyMeds and the resources we offer, and two, by letting them know about other invaluable resources and timely healthcare topics, which is why we are so pleased to have our guest here with us today. It is my pleasure to introduce our panelist, Cynthia Phillips, from the Executive Office of Elder Affairs. Cindy received her MSW at the University of North Carolina at Chapel Hill and has worked for Shine, or SHIP, for over 20 years in various capacities, and as the state director for the last 8 years. For those of you that don't know, when we talk about Shine or SHIP, that stands for Serving the Health Insurance Needs of Everyone programs. In addition to being the state director for the last 8 years, Cindy serves on the National SHIP Steering Committee, the Senior Medical Patrol Advisory, or SMP, and the Senior Care Options Advisory Boards in Massachusetts. So you can see with that robust and impressive resume why we're thrilled to have Cindy sharing her expertise with the NeedyMeds audience this morning. So without further ado, I'm going to go ahead and pass the mic and the screen to Cindy so she can take over. Bear with us while we make that transition. And let's see if you could go ahead and grab that screen. You can take it away when you're ready, Cindy. Thanks, everybody.
As you may know, I work for a state office, so we don't have all the high-tech stuff that some of the other folks do, but we do know a lot about Medicare. And I want to explain to you what a SHIP and what Shine is. So SHIP, which is the term Carla mentioned, is the state health insurance counseling program across the country. And there actually is one in each of the states and territories. My particular program is named Shine, and that stands for Serving the Health Insurance Needs of Everyone. So we believe everyone on Medicare above and below 65 years old should be helped with our program. So like I mentioned, we are funded by the Administration of Community Living, and we coordinate with Centers for Medicare and Medicaid Services, which is CMS, and all of our states and partners. So in each of the states, there is a program like this. It could be called HITEP or Choices or Shine in Florida, for example, but we're all SHIP programs. And at the end of this webinar, you'll be able to see how to find the SHIP program in your particular state. We're health benefits counselors, and we go through extensive training. We're located in senior centers and housing complexes and community agencies, hospitals, anywhere that we can meet people face-to-face, and we also have websites and telephone services so that we can meet people and get their needs addressed regarding Medicare and public benefits. So what do? Well, we provide unbiased health insurance counseling to Medicare beneficiaries of all ages. And that is the key word, unbiased. You know, there are a lot of health insurance agents and specialists and all kinds of people who are selling products. This is the one place where people can go to actually find out what their choices are in an unbiased way so that they can make the decision for them. We can meet them face-to-face or work over the phone. We do return emails. We also work in groups. We do home visits as needed. Sometimes we'll go with another staff person from the home care, for example. We're very concerned about uncovering what they need. We'll do a full assessment about, we'll look at their income and their health benefits needs and health insurance that they currently have and see what will best fit them. And then, of course, they will make a decision. We answer questions about eligibility for Medicare, the enrollment periods. There are numerous enrollment periods. You'll hear more about that, as well as benefits. And I'm also talking public benefits. We will assist people with appeals and with billing issues. We have people come in with stacks of bills. You've probably seen them yourself. We'll get the Medicare summary notice and bills and invoices, and it's just very, very confusing. So we're happy to help people with their stacks of bills. While we're doing this Medicare work, we'll screen for public assistance programs, and those will vary state by state. But there are some basic ones that we will always look at and try to let people know, what will work for them. So Medicare is a federal health insurance program for people 65 and over or people under 65 who've been deemed disabled with a significant disability. Railroad retirees also may have Medicare. Just to remember that Medicare is not Medicaid. It's for certain people of a certain age or with a disability. Medicaid is a federal service, generally for lower income individuals. So to enroll in Medicare, one goes to the Social Security office, so they can go to www.socialsecurity.gov or ssa.gov and sign up there. It is administered by the Centers for Medicare and Medicaid Services, so as you can imagine, there's a fair amount of coordination that has to happen between the Social Security office and the actual Medicare office. So part of what we do is help people understand where to go and when. There are 4 parts of Medicare: Medicare A and B, C, and D. Medicare A is primarily inpatient services, like for hospital and skilled nursing and rehab. There's also home health and pints of blood involved. Part B is medical coverage. That's primarily outpatient. It could be ambulance, physician's visits, therapies, and also pints of blood and home health when it's ordered from the community. Parts A and B are called Original Medicare, and then we'll talk a little bit about their gaps in a minute. Part C is the overall umbrella for Medicare Advantage plans or Medicare Health Plans, and they combine the Original Medicare, A and B, plus additional benefits, and often a drug plan. So that's it's a managed care plan with a few different types based on the state. That covers most of everything that people need with copays. Part D is the prescription drug coverage, and this was new as of 2006, and there were cards a year or two before that, discount cards, and now prescription drug coverage is another option for people. And we'll talk about those enrollment periods in a second. So again, people are eligible for Medicare generally when they turn 65, and they're entitled to Social Security and been paying into Medicare for at least 40 quarters or credits. People could also be the spouse of someone who's eligible for Social Security or Medicare. They don't actually have to have put in those 40 quarters themselves. They're under 65 and are entitled to Social Security disability. That has to have been effective for 24 months. So in the 25th month, they would be eligible for Medicare. People with amyotrophic lateral sclerosis or ALS and end-stage renal disease and certain other very specific disabilities might be eligible much sooner than the 24 months. And these are the enrollment periods, and I must say that this is one of the most complex parts about Medicare, and it's not even related to the actual service. So people have an enrollment period around their 65th birthday, 3 months before, the month of the 65th birthday, and 3 months after that. When that period is over, then they really have to wait until January 1st, which is the general enrollment period, unless they have a special qualifying event come up. The general enrollment period is for Part B only, and that's January 1st to March 31st, if the initial enrollment was missed. And again, the initial enrollment around your birthday would be for Part A, for Part B, and for Part D, after which time you could add a Medicare Advantage plan, which is Part C. Okay, and then one time a year there's an open enrollment period for Part C, which is Medicare Advantage plans, and Part D, and that's October 15th through December 7th, where people who already have a plan can, change the plan. They can take a look at the information they received in the mail from their current plan, check it on the Medicare website, meet with a SHIP or SHINE counselor in Massachusetts to see what their options might be. By this time, they would have received their mailing from their current plan in September, and the Medicare website, Medicare.gov, would be ready to roll, hopefully, with all of the new plans and options for January 1st. So this is the time where people would meet with their families, meet with their SHIP counselors to consider what their options might be, whether they can save money, whether they can buy a plan, get into a plan if they didn't have one before, change their plan. The whole world is their oyster at this point. There is another type of enrollment period called the special enrollment period, and that could be to get into Part B, which again was the outpatient medical services. They could get into Part C, which is the Medicare Advantage plans or the Medicare health plans, or they could get into a Part D plan, which is the drug plan. These special enrollment periods are open if there's been a qualifying event. For example, if somebody from Florida moved to Massachusetts and they had a Medicare Advantage plan in Florida that's no longer offered in Massachusetts, or a Part D plan, they can certainly switch that plan, or buy a plan, or switch a plan upon moving, and also upon retirement. And there are several other special enrollment plans as well. All right, but one of the concerns about the enrollment periods is that if people don't sign up when they're initially eligible for both Part B and Part D, is that they could be assessed a late enrollment penalty. One way to avoid the late enrollment penalty would be if someone is actively working, they're still working, they have an employer plan, it's creditable, it's good coverage. They don't actually need to worry about Part B. They could defer Part B. We often recommend people take Part A when they're first turning 65. But again, some scenarios suggest that they shouldn't get it at 65. It's a case-by-case basis with so many people. But people should really look, if they're still working or at any time, when they're turning 65, whether to pick up Part B or not. If the employer group health plan does end, or the person retires, then the person has 8 months from retirement to pick up a Part B plan without having a penalty. And again, what is this penalty and how is it applied? Well, believe it or not, the penalty is 10% of the current premium of Medicare Part B. And that premium in 2017 is $134 a month. So you'd be adding 10% times 134 plus 134 for every year that the person, or every 12-month period that the person is late enrolling. And you should also know that there are some former people are paying less than $134 a month due to circumstances, or higher than $134 a month for Part B. If their income is high, they could pay up to $428 per month for Part B. So these are all the kinds of situations that your SHIP counselor will encounter as they're helping people sign up for Medicare or talk about their options. I mentioned that there's a Part B and a Part D penalty. Well, a Part D penalty is a little bit different. It's based on the 1% of the current Part D national base premium. In Massachusetts, our premiums this past year ran from, believe it or not, $14 to, I think it was $170 a month just for the Part D plan, maybe $127, let's put it that way. So the average, however, was about $34 a month for a Part D plan. The national average, I think, was $32 a month. So anyway, 1% of the national average would be applied to the premium the person's paying every month for Part D when they get into Part D. A person can avoid having that enrollment or delayed enrollment penalty into Part D if the person has creditable drug coverage. That could be coverage from an employer. It could be a union coverage. People who have veterans drug coverage are considered to have creditable drug coverage. And again, a lot of people are in a marketplace plan, and these plans are not required to be creditable drug plans. So if people are aging into Medicare age at 65, they really need to think about what they have now and if it's considered creditable, and whether or not they should pick up a Part D plan. So if that creditable drug coverage ends, for example, when somebody retires and their employer plan is finished, they have 2 months to sign up for a Part D plan in order to avoid that 1% penalty. It gets a little confusing. So this is our favorite time of the year. In fact, we're already gearing up for that in Massachusetts, and I'm sure the other states are gearing up for open enrollment as well. Even though the date starts October 15th, we start hearing about changes in Medicare that will be happening in 2018 or January and then throughout the year. So we start to think about sessions that we want to have, PowerPoints and trainings we want to give to our counselors, and the kinds of information materials that will be available. During open enrollment, which is October 15th through December 7th, people can enroll or disenroll from their Part C or the Medicare Advantage or health plans and Part D. They can change from one plan to another. They can actually add a plan if they don't have it. And the coverage for the Part C and D and or D plans would start January 1st. Just because they're changing from or buying a new plan at this point doesn't mean that if they had a penalty in the past, that would be abolished. That's not necessarily true. So what does Medicare cover in general? Medicare was never created back in the 60s to cover everything that an individual needs. It does help to cover inpatient and outpatient services, whether they're in a facility, whether it be hospital, skilled nursing facility, outpatient, a clinic, a doctor's office, therapy in the clinic. It was not created to be the sole source of coverage, as it mentions here. And consumers have out-of-pocket costs. They would have a premium for Part B. If they did not work 40 quarters for Part A, they would have a premium for Part A. If they're picking up a Part C plan or a Medicare health plan, there may be a premium for that, and then there'd be a premium for Part D as well. There are deductibles. There's a deductible under Part A if someone goes into the hospital. There's a calendar year deductible for Part B, and there are other copays and coinsurances for all of these parts of Medicare, so it's not easy to keep track of that. Part A, as I mentioned, the deductible in 2017 was $1,316. So again, this prompts the SHIP or Shine Counselor Massachusetts to think about people's income. If someone comes to see me and I can tell that they're lower income, I'm going to be looking really careful to see that they have the appropriate coverage to make sure they don't get excessive bills. Beyond that deductible period, after 60 days in the hospital, which probably doesn't happen too often, there is a copayment as well. For Inpatient care at a skilled nursing facility, again, this would be a medical necessity skilled nursing. 20 days are covered by Medicare at no cost, but after that, there are co-payments. And again, this is a medical need, sorry about that, for skilled nursing facility, whether it be for therapy, a variety of therapies, skilled nursing care, whatever. Hospice care services are covered under Part A. There's a small fee for respite and medication. Home health services are covered for free at this point, up to about 35 hours a week. Just a note here that Medicare does not cover long-term care. A number of people who purchase Medicare think, oh, it's great, I'm all set. Now I've got my health insurance for, my medical needs in and out of the hospital and for a nursing home if I need to go in. Well, it's very limited, as you can see. You have 20 days, but only if you have skilled needs. They're not going to cover somebody who needs some intermittent kinds of care under Medicare. Part B, again, is the outpatient types of coverage, and there's a calendar year deductible of $183, and that generally changes every year. All of these services, except some of the preventive services, are covered at 80%. Who's going to pick up the 20%? Right, and that's why we're thinking about, is A and B enough for every single individual? There are deductibles under Part A, there's deductible under Part B, and 80% is covered under your outpatient services, whether it be therapies, physicians, ambulance, and tests too. So these could add up to a lot of money for people. Preventive services are a wonderful addition under Medicare B, and there are all types of services, from wellness visits, smoking cessation, aneurysm screening, flu and pneumonia shots. Some of these are free. Some of them require some sort of deductible to have been met. The Part D under Medicare, again, is only outpatient prescription drug coverage. When somebody is in a skilled nursing facility or hospital, the prescriptions are covered under Part A. You can enroll in Part D if you have either Part A or Part B. You do not need to have both in order to enroll in a Part D drug plan, and it's voluntary. We're not going to come to your house and make you sign up for Part D, but, and people so do decide that. If they don't have any prescriptions, a lot of people will decide not to sign up on Part D, which is okay, except if you need the prescription coverage later, and then find that you've been assessed a penalty because you should perhaps have signed up when you were first eligible for Medicare. When somebody comes to see me who has absolutely no medication costs, I probably will recommend they take the least expensive plan just so that they're not hit with a penalty or an inability to get into the Part D plan when they really need it, which can happen. These Part D drug plans are delivered by standalone drug plans, or they're wrapped into a Medicare Advantage or prescription Medicare Advantage plan. And if you need prescription coverage and you have a Medicare Advantage plan, you have to take it from that particular company. You can't add a prescription drug plan and have a Medicare Advantage plan. One will cancel the other out. So the Part D standard benefit is, it's a little bit of a conundrum, but generally prescription drug plans are allowed to have a deductible attached to their drug plan. It can be $0 deductible up to this year, a $400 deductible. So some plans will have, you sign up for a plan, then you go to the pharmacy, and either your coverage starts right away because there's $0 deductible, or you have to pay until that deductible is met. So if you have very few prescriptions and you get a $400 deductible plan, you may never get to the next phase. So you have to be really careful about which plan you take. The initial coverage period is when your plan is in operation and your drug plan is paying 75% of the full cost for your medication. You're paying 25% of that cost, which is generally the copay amount, depending on the prescription. After a certain amount is paid out, then the coverage gap period starts. And it used to be that there was no assistance in the coverage gap, and the individual had to pay 100%. But because of the Affordable Care Act, there were arrangements made with the pharmaceutical companies that a certain percentage of generic and brand names would be covered during that period. That's very helpful. When, again, that period is over, a catastrophic period where the beneficiaries' co-pays are about 5% of the cost of the medications kicks in. So, it's a kind of unique coverage phase, a scenario that changes a little bit every year until the year 2020, knock on wood, when the coverage gap will be filled and the individual is paying 25% of the medications year-round. Now, just so you think that's going to be a panacea, it means consumers are paying 25% of their medications year-round, and that will still potentially be expensive. You know how the cost of drugs are these days. Okay, and as I mentioned in Massachusetts, for example, as in all the other states, the premiums range dramatically. In fact, we had a meeting recently with some of the other states, and in Puerto Rico, for example, there's only one drug plan available, and it's expensive. So each state has their own set of plans and their own set of premiums. In Mass, it was $14.60 to $127 a month. And so, again, that's going to be a case-by-case basis for each individual about which plan will work the best. And the deductibles range, too, from $0 to $400. The co-pays per plan per medication range. There's 5 tiers from the generic all the way up to the brand name, to the preferred brand name, to the expensive. There are many, many options for people, which is why the SHIP program is so important to help people understand their options. The formularies vary. There are a certain number of prescriptions for each drug class that are required to be covered by the Part D plans, but they don't have them all on their formularies, and they change from year to year. In fact, even when people go through this review of their medications and options in the fall, the drug companies are allowed to change their plans or their co-pays, or they change their drug manufacturers, which could result in different results from what they saw on the website. So, there's always something to keep track of. The prescription drug plans also may have different drug restrictions in order to manage use of those prescriptions. For example, if a very expensive medication may require step therapy, and that is where the individual is required to use perhaps 1 or 2 generic medications to see if those will solve the issue, and then go up the ranks of the types of medications until the right one is found. Some medications, of course, like narcotics, require prior approval from the drug company or the physician, and there are quantity limits. You may need to have 60 pills per month, but that may not be allowed by a particular plan. And then you would have to file an exception, the quantity exception, or some other kind of, appeal situation. Each Part D plan has their pharmacies that they like, and the pharmacies that they are non-preferred. And that can even change during the year, we've found. Somebody will pick a plan, it looks great, they start January 1st, and all of a sudden the pharmacy that they had selected on the website is no longer the preferred pharmacy. So then there's troubleshooting to find the right pharmacy that will reduce that cost. No black and white. Here is the Medicare Plan Finder. Again, it's Medicare.gov. Anybody can go into it. You don't need a SHIP counselor to actually look for your Medicare drug plan. And there's a lot of other information on Medicare.gov too. There are quality suggestions and advisors and lots of different information about Medicare and other options. So if you have time, go in and check it out. It's a lot of fun. You can do a plan search based on your zip code alone if you're just curious about what plans are available in your area, or the search that we recommend and that we use with the people who see us are to look at the zip code actually put in the Medicare number and some more specific information. Sometimes people won't remember what exactly they have for a drug plan already, or whether they have extra help to pay for that drug plan, and the information that's captured on Medicare for this individual will be revealed through a personalized search. So we find it much more effective for people that we're trying to help. Here are some other interesting search tools. And there's actually a very nice plan finder tutorial above if you see the arrow, and that will walk you right through it if you want to try that out. So how do you pay for Part D? You know, I mentioned there were a lot of different costs. The extra help or low-income subsidy is the assistance to help people pay for their Part D plan. People who are eligible for extra help will have help with their premiums, the deductibles, the co-payments, and the coverage gap. They can even actually change their plan on a monthly basis. The late enrollment penalty, which some people may have, would be waived if people are low income enough that they are eligible for this extra help plan, and that way they don't incur those additional costs. And as I mentioned, there's a continuous special enrollment period, so that people who have extra help and are low income, if they're having difficulty with the current plan, it doesn't meet their needs, their prescriptions change, they actually could change their plan the next month. Somebody with Medicaid, because they are low income and asset, are automatically enrolled in the extra help plan, so that they are, you know, right away taking advantage of this assistance to pay for their Part D plan. The way that someone applies for extra help is through Social Security Administration, and it can be done very easily online. www.ssa.gov, and there's a link right to the application. You don't need to be somebody's representative payee or even their caseworker in order to help them get this started. And the database will match up with whatever information is on the Social Security database regarding the Social Security check. And then if additional information is required, that will be forthcoming. So we mentioned that there is Medicare A, B, C, and D. We mentioned that Medicare A and B are called Original Medicare, and we talked about some of the gaps. And those primarily are the deductibles for both Part A, when you go into a hospital, calendar year deductible for Part B, the 80%, which is covered by Medicare, hence leaving the beneficiary with 20% to cover, and other costs that people would incur depending on the type of service that they have. There are a number of different ways to fill those gaps, and most people would like to fill the gaps and not feel that they are vulnerable to these expenses, which could wipe them out, frankly. There are Medigap plans, Medicare Advantage or health plans, Medicaid for people who are lower income. The state pharmacy assistance programs are very helpful, and I think about half of the states have one of them right now. There are special prescription programs like NeedyMeds, and I'm sorry about that typo right there, but you know what I mean. NeedyMeds is a wonderful program where you can go online or get assistance to find additional help for prescriptions. There are retiree plans. We're seeing a lot of action with retiree plans where companies are converting to a broker and then giving people choices. You know, rather than cover them entirely for their retiree benefits, they're giving a fewer options, perhaps with a little bit of a paycheck or a few dollars to help pay for it. But we're seeing a lot of changes in the retiree plan field. Veteran and military benefits. We always talk with the individuals who come see us and ask if they're veterans or spouses of veterans, because we can work together with what the federal government and what the state government offers to help them cover their particular health care needs. And those can be jiggled, depending on the particular health care service that the person requires at the time. You could select veteran or Medicare. And again, we can work with our particular veteran service offices in each town to maximize the coverage that somebody can get for their health insurance. So once again, original Medicare is Part A and B. Individuals could supplement Medicare or fill those gaps by adding a standalone Part D plan, which, as I mentioned, in Massachusetts was $14 to $127 a month with potential deductibles, and add a Medigap plan. Now in Massachusetts, we're one of the 3 states, I believe, that has a waiver to what the other states have. So we only have a couple of Medigap options, but again, that would fill those gaps but not cover prescriptions. In other states, there are many plans available, and in fact, these are all a little bit being tweaked right now, but those would be available for view, I believe, on the Medicare.gov website to have a general idea of what Medigaps are available. The Medicare Advantage or health plans, or Part C, wraps in original Medicare, A and B, and a drug plan, and provides the services that one would have under Part A, D, and with a Medigap. And some extras. Sometimes there's gym membership, or there's an annual physical. Drug plans are generally covered, and the premiums and copays range dramatically. Every year, we analyze what our Medicare Advantage plans are offering for January by county, and they vary. We have maybe 7 Medicare Advantage plans with a number of plans under each one of them, and they all range based on coverage, premiums, deductibles. So it's a very interesting puzzle to solve during the fall when we get ready for open enrollment. The Medigap plans are sold by private insurance companies, and Medicare beneficiaries must have Part A and B, both together, and continue to pay the Part B premium. In Massachusetts, we only have 2 types of plans: a core that runs about $90 a month, and a supplement 1, which has better coverage for the gaps, which run about double that, $180, $190 a month. So again, it's a pretty clear choice. It pays secondary to Medicare for Medicare-covered services only, and in our state, we're fortunate that they're open all the time. It wasn't always this way, which made it very complicated. And as I mentioned, these Medigap plans vary by state, so you really would benefit by talking with your state SHIP counselor or calling them and ask what's available in your particular state. And then in bold, of course, you should note that Medigap plans are not allowed to offer prescription drug coverage, at least here, so that people would need a Part D plan to go along with that if they want drug coverage. Or they could use the Veterans or Union drug coverage if they happen to have that. The Medicare Part C, Medicare Advantage, or Medicare Health plans are private plans that are contracted with Medicare and subsidized somewhat to offer a managed care product to people with original Medicare. It includes Part D coverage, and as I mentioned earlier, you can't have both. You either have a Part D and maybe a Medigap plan, or a Medicare Advantage plan that includes prescription coverage. Plans are able to offer benefits like dental checkups and a little bit of dental work, some vision screening, eyeglasses, hearing aids, gym membership, Weight Watchers. There are other benefits that may be offered. And you may be surprised to find that you get a number of bills. The plans could charge additional premiums and copays depending on the type of service. So it really does take a full analysis of your healthcare needs to help you determine which way to go in terms of supplementing your Medicare, your original Medicare. Medicare Advantage plans could have a selective network, or they could have a broader network, like a preferred provider group, which expands. You could potentially pay more for your plan and then be able to see more providers. It's a very individual offering. So again, with Medicare Advantage, you must have Parts A and B and continue to pay your Part B premium, which, as you recall, is about $134 a month. You need to live within the planned service area for at least 6 months of the year. And if you're out of the service area, not use the plan except in an emergency situation or urgent situation. You cannot, at this point, in this year, have end-stage renal disease. There might be some plans coming on board that will allow that in the future. So here are some of the advantages and disadvantages. If you have original Medicare and Supplement 1, which is what we offer, and covers all of the services that Medicare does not cover except prescription drugs, there's a higher monthly premium, but you have the benefit of not seeing a lot of bills coming in for co-pays for services. So you've got one bill, which is your premium, and that's it. You can choose your own doctors. You could go to, whatever doctor you would like and not worry about them coordinating, not worry about, a more restricted kind of situation. There aren't any referrals necessary. Some of the routine services aren't covered, but you might like to get covered. Those are vision, hearing, and dental, and other offerings. There is an annual physical that's not covered. When people join Medicare, they could have a Welcome to Medicare physical, but pretty much that's the only physical that Medicare is going to allow. And therefore, since Medicare doesn't allow it beyond that point, neither will the Medigap Plan. The Medigap Plan will allow for an annual wellness check, but again, it's not an annual exam or physical. If you choose the right Medigap Plan, you could be covered anywhere in the United States and abroad. And again, this sample is based on the kind of plan that's available in Massachusetts. The plan available in other states may be different. And again, seek your SHIP counselor because they will know all of your options and how they work best together. A Medicare Advantage plan or Medicare Health Plan might have lower premiums. We've seen some for $0, up to about $100 a month for Medicare Advantage plan, but then the co-pays might be higher. If you choose a zero premium plan, there's a chance that your doctor's office visit will be $30 instead of $15. So again, it might depend on your use and your projected use, which way you want to go. There is a restricted network. Sometimes it's a very broad network. Sometimes it's really quite narrow. And if you have proclivity to go to a particular provider or hospital, that needs to be part of the discussion. You may need a referral for specialists. Some specialists like nutrition counseling or a mental health counseling, you can pick up on your own without worrying about a referral from your physician, but others you would definitely need a specialist and to have spoken with your PCP first. There may be extra benefits. There may be a benefit toward a hearing aid or toward eyeglasses. You'll have a screening for hearing, vision, and dental, and the annual physical is covered. So some people do really feel that physical is important to them. And again, you might have the physical, but then find that, oops, you have to pay for the lab work, that goes with the physical. But it's just one more thing to think about. The emergency services, as I mentioned, can be out of the service network. They're allowed, and so are urgent care services. If you need that out of your Medicare Advantage Plan network, we recommend you call within 48 hours to make sure that you get coverage for those services. An ongoing chronic disease treatment is not going to be covered by Medicare Advantage Plan out of the service area. So some of the questions that we ask people when we're helping them decide whether to choose a Medigap to go along with their Medicare plan or Medicare Advantage or health plan are, do your current doctors accept the plan that we're talking about or the plans? Do you want to switch? Does it make a difference to you where you go for your care? I mean, are you willing to go to a community hospital that has referral capability to the expensive hospital in town. Will that work well enough for you? Will you feel satisfied by that? Is the physician you go to now somebody you really trust? How much are your co-payments? If you have an ongoing need to see a physician, what is that going to look like in terms of your bills? What is the out-of-pocket maximum per year? Another advantage to the Medicare Advantage plans is that there is a limit to what you'll pay out of your pocket. It's generally less than $3,600 to up to maybe $7,200 right now, and that may change. We need to look at that bottom line for your out-of-pocket risk. And as I mentioned, you might choose a Medicare Advantage plan with a low premium, but we'll see higher copays in terms of your outpatient surgical services or some other kind of treatment that you get out of the hospital. That's something to think about. Are your medications on the formulary? Sometimes there's a medication that can be changed. You might want to take your medication list to your physician and ask if there could be a switch, or even consult with a pharmacist to think about other medications if they're not on the formulary of the plan you would like to sign up on. How much will they cost? How much will they cost now? You may see a forecast for what your prescriptions cost on a website, and it looks great, but you need to know that that's a range, it's a snapshot, and it may change in the future. And, what will you do if your prescriptions go up? Are you eligible for extra help? What is your income? Is there a senior pharmacy or a state pharmacy program in your state that could help you out? Is there a NeedyMeds? Do you know about NeedyMeds? All of these things are part of the discussion around options for seniors. And then again, does your doctor participate in the accountable care organization where they're exchanging medical information and coordinating services beyond what you may be receiving now? I mean, this is one of the great occasions when people are worried about whether they're in the hospital on observation days or whether they're actually admitted to the hospital. A lot of these providers that participate in the accountable care organization can refer to a skilled nursing facility without having had the 3-day in the hospital requirement met. So there are all kinds of factors about health care and medical care that people should consider as they're going forward every year and as they evaluate their needs every year. So I'm just going to talk a little bit about some of the public benefits that are available to people. Generally, the public benefits for people with medical needs who are lower income are called Medicaid. And it provides a broad range of medical benefits: inpatient, outpatient, skilled nursing care, drug coverage, home and community-based services that people can actually get to stay home instead of go to a nursing home and they're nursing home eligible. There are lots of eligibility rules, and each state may have different features of their Medicaid program. So that's really something to look at when people are lower income. There are also programs that help pay for the Part A and B premiums. That's Medicare savings plans, deductibles, and co-insurance. The extra help is really important to help people pay for Part D, the premium deductible, and to reduce their co-payments for prescriptions. The whole idea is to keep people healthier. Is people with good health insurance, people who can afford their prescriptions and take them when they're recommended or as recommended by their physician, are going to be healthier. Long-term care Medicaid is a different type of Medicaid, and this is a program that helps people stay in a nursing home when that is needed. Clinical eligibility is required. It's a different application or addition to an application than your typical Medicaid application for community services. Both of these plans offer full extra help. In a nursing home, for a person that's in the nursing home, there's no co-payment for prescriptions. These are the types of applications that are completed. I think each state may have a little bit of different name for what they might be called. Massachusetts or the ACA and the SACA, and we have a long-term supplement. But generally, most states have a type of Medicaid program that helps the most low-income and in need. Medicare savings programs I mentioned before help pay for Part B. The QIMBY, or Qualified Medicare Beneficiary, pays A and B co-payments and deductibles in the hospital, too. So, that's really a great benefit for people who are pretty low income. Then there's the plan, the SLIM-B and the QI1 that helps pay for Part B. And just to mention, the Part B premium for new enrollees is $134 a month. Prior to that, it might have been $109 per month, and it all depends on people's income, whether they were actually bumped up to $134 a month. Each year it tends to go up a little bit more, and can be expensive for people on fixed income. Here's a little case example. Her name is Lucy Jones, and she's 65. Her gross income is $1,134 a month. Her check is $1,000 from Social Security. She has $5,000 in a savings account. She lives in her own home, and generally the home is not looked at in terms of eligibility for community mass health or community public benefits. So $5,000 might look like a lot, and if we were looking at Medicaid for her, she would probably have to spend down to $2,000 in savings. But in this situation, we will look at different benefits. So again, the benefit that she would be eligible for would be Medicare buy-in program, and that would help her pay for her Part B premium of $134 a month. So that's cash back in her pocket that she can use for whatever she needs, and it will automatically sign her up for extra help, full extra help, which will help pay for her Part D plan and her prescriptions, and she won't have to worry about a coverage gap. And so this is like, Christmas, Hanukkah, and all the other holidays together for Lucy Jones. So again, we do advise people, if you have any health insurance questions or want to get in touch with a SHIP counselor, please do. Here are some of the resources to find SHIP. If you have Medicare questions, you can go to Medicare.gov or call them. If there are specific state questions, they will often refer back to the SHIP program, State Health Insurance Counseling Program. To find a SHIP program in each state, you can either call the SHIP Technical Assistance Center, SHIP TA Center, or go to the website. And that's how to contact us. So I believe that that's the end of my presentation.
Fantastic. Can you hear me, Cindy?
I can.
Fantastic.
I'm going a little bit more. I'd love to hear some questions.
Yeah, we're going to go ahead and before I take over and just supplement a little bit of what Cindy was talking about. And what I'm going to do is go ahead and take some questions, and I'll encourage you, you being our audience, to go ahead and type in any questions you may have into the GoToWebinar control panel, into the questions section. So one of them, couple of questions that are coming in, and some of these are really going to be applicable to a lot of people, I think. One of them is, do SHIP or SHINE locations work with veterans?
Well, that's a good question. In fact, we try to work hand in hand with our veterans service officers. We will do a presentation to all the veterans at their conferences a couple of times a year to let them know about public benefits. In this state, at least, we have the federal benefits, but also state benefits. And each town is responsible for chipping in to help their veterans have good health insurance. If we can help them get onto Medicaid, for example, when they're eligible, instead of spend that veteran service money, then that money could be used maybe for a ramp to help somebody get into their home easier, or to help support the premiums of the spouse for his or her health insurance. So, we do find that it's really a great combination where we work together with our veterans. And in
That's
fact,
fantastic.
Depending on the service, people could use Medicare for one particular need and the veteran service for another.
Oh, that's a really important distinction, and again, probably applicable to a lot of people listening this afternoon. That it's good to know it doesn't have to be one or the other. Depending on the situation, you can dip into one to cover a need, and the other to fill the gap.
Well, actually, you do have to choose one or the other, but you do have the option. So,
you have the option for whatever makes sense to your particular situation.
That's right.
Got it.
For example, if you needed chemotherapy on a regular basis, you wouldn't pick the VA hospital that's 100 miles away. You would maybe choose your local hospital.
I see. Yeah. That's a great example.
So thank you. Yeah, thank you for mentioning that.
Yeah. Another one coming is and I think you did address this a little bit ago, maybe expand on it a little bit, that a number of companies are changing their retiree plans and using a broker that might have a limited number of choices. How would you work with that retiree?
Yeah, the interesting thing in this case is that we've seen huge retiree plans, and I'm talking about big companies, tell their managers 1 year, and then their other workers the following year that, well, we're switching you out of this retiree plan, and now you go into this broker system. Here's $1,000. Through the broker, choose one of these 5 plans. Well, it can be confusing about, gee, is $1,000 enough to pay for the right plan? And so they might want to consult with a SHIP counsel at that point, just to see, well, what's available if I went to Medicare and instead went through those options versus the $1,000 and what my retiree company is offering. Sometimes, we can go with the money. It will benefit you, and this is okay, and this is the one that looks like it will meet your needs best. But sometimes $1,000 dries up, and we have seen that it was $1,000 one year, the next year it's $500, the following year it's $0. So are you going to stay with that broker in those 5 plans, or do you want to be reevaluated by your SHIP counselor to see what else is available for you?
That's fantastic, and I think, as much as I was listening to how robust filled this presentation was, I think the point that always resonates with me the most, and hopefully our audience, is certainly this can be so confusing and overwhelming, and it's a crucial there are crucial decisions to make, ensuring that you have access to the health care you need or your family members do. And what really I just want to drive home is you don't have to do those decisions, make those decisions on your own. You can turn to an expert SHIP or SHINE counselor to provide you with the feedback, the resources, and lay out the options clearly, so you're not trying to guide your way through what is a very confusing decision to make.
Thank you very much for mentioning.
Oh, absolutely, absolutely. We do have a few more questions coming in, and again, as I said, we're not going to spend tons of time on the question portion. Looks like we're already running out of time. We're going to take a couple more, but for those of you that we don't get a chance to respond to personally, we'll follow up with you again via email or phone call within a day. So another question that came in was, Cindy, is there a time limit or limit on the number of days of service for specifically home health care?
Well, the home health care information that I have from Medicare is that they generally recommend up to $35 an hour. I'm sorry, $35 a week. $35 hours a week, sorry.
Okay.
But, I believe that it's certainly worth a discussion with a home health agency about the needs of the individual. And we also find that personal care and nursing services and other types of support may be expanded depending on what the individual is eligible for. You might have palliative care. You can even, there's so many programs out there, really, that you could match home health from Medicare with home health from the VA, and with aid and assistance programs to expand that if necessary. Or you could go through one of the special Medicaid programs like home and community-based services, which have expanded services at home. So again, the general rule would be 35 hours a week. But there's so many other ways to look at that and see what else is available. That I wouldn't give up if more of that is needed.
And that's one of the things that we, and one of the reasons we are so fortunate to have Shine as such a great partner of NeedyMeds, because we both have the same mindset that neither one of us are the magic bullet or the magic solution for everybody's problem, but we will both try our best to be creative about getting you the coverage that you need, which brings us into another question coming in, was whether or not there's any help to lower the Medicare, specifically the Medicare Part B premium cost.
To lower the Medicare Part B premium, which is $134 a month, if people are lower income, the Medicare savings plans will help them, will pay that, in fact.
Got it.
But again, if you're not lower income, it'll be difficult. Yeah.
And if somebody is interested in applying for Medicare savings programs, do they go to the Medicare office or the SSA office or both?
Mm-hmm. Right. Well, in this state, and I can only speak for this state, you could either complete a full Medicaid application, which is very lengthy, requires a whole lot of documentation, or if you think maybe you're higher assets and you wouldn't be eligible for Medicaid, you could complete a short application, but both of those are handled through our Medicaid office. So you would call that 800 number directly, or you could contact a SHIP counselor who has all that information readily available.
Great. And again, I'll ask Cindy if you could now actually, Cindy, to transfer the screen back to me by just hitting the presentation option on your GoToWebinar control panel, because what I want to do is just point out a couple of other resources that NeedyMeds has, which may provide you with an additional safety net or additional cost savings resources. And while we make that transition, thanks, I've got it. Thanks, everybody. Hopefully you can see my screen. And one final question that was coming in, where does someone apply specifically for the Medicare buy-in programs?
Well, the problem is we've just heard Medicare Savings Program, Medicare Buy-in Program, and they're kind of interchangeable. So, but you highlighted the perfect problem is that the same name can be, or several names can be the same thing. So for Medicare Buy-in Program, even though it sounds like you should go to Medicare, you don't. You go through the Medicaid office.
I see. Thank you. This could be very confusing, and that's why I'm going to stress again, when in doubt, there's no reason to struggle on your own. Give your Shine counselor a call. Again, if you do have questions, we're going to wrap up the questions section right now, but don't hesitate to continue submitting your questions. And again, we can certainly follow up with you via email or phone call. Before we do wrap up, I want to point out again, Cindy has mentioned NeedyMeds. For those of you that are interested in learning more about NeedyMeds, check out our website and join us for one of our monthly overview webinars, which will let you know some of the cost savings resources we have available. We pride ourselves on providing all of the information anonymously and free. So don't hesitate to give also a NeedyMeds expert counselor a call on our 800 number or visit our website. I'll leave those details up on the screen as our last slide, but also you will find that slide in the copy of the PowerPoint presentations that were attached. Some of the cost savings resources that NeedyMeds offers are things such as the prescription assistance programs, which are programs supported by pharmaceutical companies that offer free brand name medications to those that qualify. We also have diagnosis-based assistance programs, or DBAs. And DBAs are programs that really don't offer help usually for medication. What they offer is assistance for things that fall outside of medication, such as maybe travel expenses to a doctor or specialized facility, maybe testing supplies, durable medical equipment, or maybe even some assistance for respite care. We also have a database for coupons and rebates, and we always recommend using the NeedyMeds drug discount card to save money if you're not going to use your insurance. So again, if you'd like to learn a little bit more about each of those programs and other resources we offer, join us for one of our overview webinars. We actually have an evening webinar scheduled tomorrow night. We put that on because sometimes people don't have the opportunity to join us during the day. And I'm also leaving you with some of the upcoming webinars through the end of the month and the very beginning of August that I think some of our audience that's listening in today may also be interested in. And you can log into those or register for those webinars on the NeedyMeds website. In the bottom right hand, you'll see our calendar of events, and you can click on any of those free webinars that you may be interested in. As promised, I want to go ahead and leave you with the contact information. At the top, you can see the website and toll-free number for Medicare. The middle contact information is for SHIP. Did I get that right, Cindy? Does that look like the right website address up there? Great. And of course, their 800 number. And again, there's the phone number for a NeedyMeds counselor if you're looking for additional assistance or cost savings options. We'll also let you know we have convinced Cindy, because you can see how extensive her expertise is, to come back and join us. I think it's going to be in September for around open enrollment, right, Cindy? We're going to do another presentation then. So check out, we'll get that up on our website soon, so please feel free to check it out and register for that right away. Otherwise, please stay in touch. Thank you, Cindy, for sharing your expertise with us, and thanks to the NeedyMeds audience for taking time out of a busy workday to enjoy our presentation. Thanks, everybody, and take care.
Thank you, Carla.
Bye-bye.